today's topic is managing a drowsy child, navigating the care at the PCU. To deliver the lecture, I would like to invite Dr. Michael Jansz, consultant pediatrician at the preliminary care unit of LRH. Dear sir, over to you to conduct your lecture. Thank you.
Thank you for having me speak on this topic. So when Vasan asked me to speak on a topic, I thought of this one, this drowsy child. So over the years, we have seen so many patients like this, and it's a common thing. And the thing with this is all the children present in the same way. They come drowsy, but it can be very challenging because there are many diagnoses for this, varied diagnosis. So if we don't come to a correct diagnosis, we go on the wrong path, we'll run into trouble. And the other thing is challenging because many of the cases in which children present to us with drowsiness, they are life-threatening conditions. So we have to treat. So we have three things at once. We have to assess. We have to assess the patient, manage the patient, as well as take history examination and diagnose and treat it all at the same time. So we have to prioritize. It's very time dependent because there are emergencies. We have to do the right thing at the right time. If we do unnecessary things, we'll be wasting time and putting the child in danger. So all this will be happening in a very high stress environment. So child is drowsy, parents are worried, sometimes your staff is pressurizing you, and so there are a lot of distractions. So it's very difficult to see what to do at once. So to teach this is very difficult. So I thought I'll do some cases, and as the audience, we'll try and work out how to manage and diagnose and treat. So we'll be doing only the initial management. Many of these diagnoses have much more things to be done, especially if there are registrars there, there'll be much more things to be done, but we'll be talking about only the initial management. And before we start, I thought we'll just give some of the causes of a child who presents with drowsiness, as well as some of the investigations, as well as give an outline how we approach them in the ABCD method, in a structured method, so that we can save the life while assessing the patient. So if we look at the causes, hypoxia is an important cause. So even though we think drowsy thing, we think CNS, other systems also will cause drowsiness. So even though it seems obvious hypoxia, we should be able to diagnose, sometimes we miss this. If we don't go in a structured manner, all the problem might be hypoxia. You give some oxygen, might need ventilation, that is the problem. So hypovolemia is like that. So child might be in shock. We might be treating for meningitis. See, the actual problem is child is in shock. So these are important that we manage this in a structured manner. So epileptic seizures, again, we think this is obvious, but it's not always so. Sometimes the patient is having a subtle seizure and reduced conscious level. So they might only have some eye movements, dilated pupils. Sometimes it's so subtle that we can't even diagnose without EEG. So trauma, again, we think this is obvious, but we see so many patients, they don't give the history of trauma. We have to dig into the history and later only find there's a trauma and a hemorrhage. So infections like meningitis, encephalitis, cerebral abscesses. So malaria we don't see, but even that we can get a patient from abroad who can present with reduced consciousness. So metabolic causes are very important. So never forget hypoglycemia. So this is the commonest cause that we will probably see in the emergency department. And remember, even high sugars can cause. Hypoglycemia also can cause. So always look for encephalopathies, renal or hepatic failure. So history examination, investigation, look for these causes. Electrolytes, sodium is a very important thing. Low sodium, high sodium, both will cause reduced conscious level. Inborn errors of metabolism. So if you have children, consanguineous, family history of metabolic disorders, come in dysmorphism, fail to thrive, odors, think of inborn errors of metabolism. So another common thing that we get in the emergency setup is drugs, intoxication. So alcohol, various medicinal drugs, recreational drugs, sometimes accidental or non-accidental. So snake bite, if you are in the dry zone, this is a very common thing that we see. So it's so common that the HOV will diagnose that is the cause for reduced consciousness. So Anuradhapura, when they come with reduced consciousness, we won't think of anything else. We know this is a snake bite. So hypothermia, hypocapnia. So even after a fit, if we have not maintained the airway, if carbon dioxide is high, the child will continue to be drowsy. Another important cause, hypertension. So if you have hypertensive encephalopathy, another cause. So if you don't check the blood pressure properly, so we have seen this children drowsy, blood pressure not checked. When we check, blood pressure is sky high. So cerebral tumor, these are rare causes, stroke, AV malformations with rupture, central venous thrombosis, hydrocephalus, including blocked shunts. So we'll have to do some basic investigation. So important, always check the sugar. So blood sugar, CBS at the bedside. For infections, we are looking at full blood count, CRP cultures. You may even need a LP. So don't forget liver functions, renal functions. If indicated, we might need the imaging. So in an emergency setup, if you want it done quickly, it will be a non-contrast CT of the brain. So very rarely we can't find a cause. We might, if we are suspecting a convulsion, we can't diagnose, we might have to do even an EEG. We are looking at the causes. So the causes, when you know the cause, you can ask the history and examination and confirm maybe the investigations. But in the emergency setup, if we go to ask the history, we are asking about things and we leave the child alone and don't manage the child might die. So if the hypoxic patient or if it's a child with reduced conscious level and the GCS is very low, the tongue might fall back, the airway might get obstructed, and while we are taking the history, the child might die. So it's always important that we first assess and manage the patient. So when we assess a ill patient, we should always go in a structured manner. So this is the way method is. We say airway, breathing, circulation, visibility, exposure. So not enough saying A, B, C, D. We must know what we are looking at it. So these are very simple things, but unless we practice over and over again and get into our spinal system, we forget. So even though we say airway, we forget to look what is in airway. So see whether the child is breathing properly. See whether is apneic. If you have a snoring sound, that means, and child is drowsy, that means the tongue has fallen back. So you might have to do a airway maneuvers, head tilt, chill lift, and reassess and see whether the sound is disappearing. If conscious level is very low, you might have to put a oropharyngeal airway. So if there are secretions, suck out the secretions. So clearing that and giving some oxygen, you will help to save the child's life. But if you don't do that, then you are taking a history while not assessing and managing, while you're watching, patient can arrest. So like that, the breathing, we have to look at the respiratory rates and work out breathing. And if there's any distress or low saturations, we'll have to start oxygen early. So don't forget circulations, check the pulse rate, volume, capillary filling time, blood pressure, cold line, urine output color. So check all these parameters. From that, you will get information. So if in shock, treat the shock. So there is features of shock. Put a cannula, take bloods, always take the sugar. And the shock, you will have to give boluses, maybe 10 to 20 ml per kg and reassess and see. Sometimes we see patients, they are coming drowsy. They are in shock, either due to dehydration, diarrhea and vomiting or septic shock. When you give the boluses, their conscious level improves. The reason is hypovolemia. So when you're putting a cannula, always remember to check the sugar if you're having a child with reduced conscious level. So the D is what we are concentrated in this lecture. We are checking three things in the acute situation: the conscious level, posture, and pupil. So when you are checking the conscious level, we are checking either the AVPU score or the GCS. So AVP means alert. This patient is alert, respond to voice, respond to pain, or unresponsive. So anything less than alert, you should be always worried. If your child is anything less than alert, you see a red flag, you must find out what is wrong. So if the responding to pain or less, you have to be even more worried. That means the GCS is less than 8. The GCS is less than 8, it means your airway is compromised. Chance the child can aspirate, can block off and get hypoxic. So this is the GCS chart, sometimes difficult to remember. So always have it on your phone or in your ward so that you can check formally what the GCS and see whether it improves with treatment. So there are, for less than 4 years, there's one chart. For bigger children, there's another chart. So in the D, we are looking at conscious level, posture, and pupil. So we see here, this is a abnormal posture. Can you see this This is decorticate posture. This is decelerate posture. So this is very important. This is a sign that there is raised intracranial pressure. If you see this, you know there's something going on in the brain. Some pressure is more. And always important, the next thing is the pupils. So see whether the pupils are small pinpoint, bilateral fixed or unilateral dilated. So small pinpoint ones are the lesions are a little less, medullary pontine lesions, narcotics like narcotic or organophosphate injection. So bilateral fixed pupils, think of raised ICP, whether there is coni, that means severe coni, severe hypoxia, hypothermia. You can get dilated pupils during and post seizure. So if you have a unilateral dilated pupil, that means there's a focal lesion, probably early herniation, but also a sign of raised ICP. It also comes in third nerve lesions. And if you have a focal seizure, you might have one side pupil dilated, one side of the where the seizure is originating. So a little bit, if you're looking at the drowsy child, you should know the features of what raised ICP. There's increased pressure in the brain. So if you have any abnormal postures, like I said, decortic or decelerate pupil posture, or if you have any abnormal pupils, bilateral dilated or unilateral dilated pupils, think of focal lesion, think of raised ICP. Also, always look if the child is having abnormal breathing patterns. If they have a severe raised ICP, they can have apneas, intermittent tachypneas, and various abnormal forms of breathings like chain strokes breathing. So, you know what Cushing's triad is? Near the MOs. So, you know Cushing's reflex, no? What is Cushing's reflex? With raised ICP? Anyone? So, increased blood pressure, bradycardia, and the triad here is abnormal breathing patterns. So this is generally a late sign of raised ICP. The thing is abnormal oculocephalic reflexes. If you turn the child's face to one side, the eyes should normally go to the upper side. So when you turn this head to the side and you see the eyes are not moving or moving randomly, that is a sign of raised ICP. Right? So remember, we just generally look at the fundus, papilledema, but in the acute setup, acute raised ICP, there might not be any papilledema. So don't go only on papilledema for raised ICP. So exposure, while you're looking at the patient, there are clues to the diagnosis. So temperature, if there's fever, think of meningoencephalitis, meningitis or encephalitis. If rashes, it might be a meningococcal rash, meningitis. Look for neurocortinous stigmata, that is neurofibrinosis. If that is there, it is probably a fit, right? So if there's, always look for trauma. If there's any bleeding from the ears or nose. So if it's there, then reduce consciousness, think of a bleed inside. So neck stiffness. If there's hepatomegaly, think of a metabolic or a cause of liver failure as a cause of the drowsiness. So when the patient comes to us with dryness, always go A, B, C, D. So while we are doing this, parallelly, somebody will be looking after other stuff in the patient. So measure the sugar, measure the temperature, take adequate bloods, take the CBS. If indicated, you might take other full blood count, CRP, electrolytes and stuff, right? Get a cannula in. So you want to get as much information as possible, put on all the monitors that you are able. Saturation monitor, BP, ECG. Sometimes it could be arrhythmia causing the reduced conscious level. So always reassess whatever you do. So while you're doing this and stabilizing the child, somebody should be taking a very good history and examination. So this should go parallel. It's not one by one. As a team. So the directed history examination, you should ask the questions. We had a list of things that cause reduced conscious level. We'll go through the history trying to narrow down the cause. And once we get a cause, we can do the specific management and send the patient to either the ICU or the subspecialty that's needed. So what I thought I'll do, so the theory of it is actually quite boring and already some are very drowsy, I can see. So we'll go through some cases and try and when the cases come, we'll try to go through the ABCD approach. At the same time, take a directed history and examination, relevant investigation, and try and find the cause of the drowsiness. So we'll try and, I think if you can actively do it, and the audience, especially if the MOs and the registrars, uh, and you get the brain working, it will be more useful. Otherwise, it's very boring. So the thing is, all these patients, they present all in the same way. So since the histories, they come. So this patient is a 3-year-old boy, previously when well found unarousable in the morning. And when we look at the airway, there is a snoring sound. So anyone, what will you do? Why is there snoring sound? Snoring sound and he can't rise. If he's sleeping and snoring, it will be you're snoring, but you can't try to wake him, he's not waking. What should you do? Yeah, you have to open the airway because you can block the half and see. So first thing is head tilt, chin lift, jaw thrust. For more than 1 year, sniffing position, open the airway, see whether it's disappearing. If it's not, you might have to use a oral pharyngeal airway to keep the airway open. So child is tachypneic, what will you do? Tachypneic, what will you do? Practically. You have to tell no, the patients, you are managing patients. No? Simple things, very. What will you do, tachypnea? Anyone? Won't do anything. Yeah, that's what happens actually. Put some oxygen. Right? So tachypnea, put some oxygen. So we looked at this time, the pulse volume is good, capillary filter normal, blood pressure normal. So circulation is normal. So it's not shock that's causing. So what's the next step? So we looked at the GCS. GCS is 7. Pupils are equal reacting to light, no abnormal postures. So GCS 7, what will you do? So will you intubate? So Guyan says no, not intubating. Why? So G says less than 8, we think that we have to take over the airway. It's not always so. If there's something reversible, we can treat that and see. So don't go to intubate all the filtrations. There are reversible causes. What's the commonest cause of this child is afebrile? What is the commonest cause of reduced consciousness? Hi, hypoxia. What do you all see? So we are gone to A, B, C, D. What will you do next? If you haven't done already. Yeah, blood sugar. So always check the blood sugar. So CBS is low. So don't go and intubate this patient. Check the sugar. So CBS is low. What will you do? Yeah, you have to get a cannula and start some 10% extra. So in children, don't get 25 to 50%. We give 10% extra. So you can give 3 to 5 ml per kg followed by dextrose infusion. You will see that patient who is like half dead is now getting up and laughing and playing. Nothing wrong with him. So this is a 3-year-old child. There's no other things in the history and examination. He has not taken dinner or breakfast, fasting for more than 12 hours or 14 hours. So small children less than 5 years, if they fast for a long time, they cannot maintain their sugar. So they get hypoglycemia. So this key what is a positive? This is a ketotic hypoglycemia. But remember, registrars, always you have to assess and see, make sure there are other causes hypoglycemia. Uh, in errors in the metabolism as an endocrine. So you have to reassess all this, or most likely this is a ketotic hypoglycemia. So you should know how to assess and manage the hypoglycemia. This is the commonest thing that you will get a child with drowsiness. So second case from the back now. So it's a 7-year-old girl present with fever 2 days, cough 2 days, and drowsiness 1 day. They all present with drowsiness, and you don't know what to do. So we looked at the airway patent. So there's a mild tachypnea, lungs are clear, saturation 99%. So there's tachycardia, good volume pulse, blood pressure normal. Child is confused, GCS is 13. Child is febrile. So we measured the CBS this time is 130. What will you do? What will you do in the history and examination to find the cause of drowsiness? Anyone? Yeah. I think you'll actually do it, no? What? Yeah, you have to look for a common cause. No, this is child is having fever and high fever, confused. So always think of meningitis. No? So when you take the history, you find there's headache, vomiting, photophobia, marked neck stiffness, Kernig's positive. So meningitis. So we put get cannulas, take cultures, and we'll need third generation cephalosporin meningitic doses. Right? So this is a common thing. But the same case can present like this. 3-year-old girl, same case. Present is fever 2 days, cough 2 days, drowsiness. Identical. Same findings. G says 13. What will you do? Anyone? No one's answer. What will you do? Yeah, yeah. Don't forget CBS. Why? Yeah, CBS is high. So then what's your next step? Anyone? CBS is high. Child is drowsy. Yeah, urine coating bodies. Okay, anything else? Yeah, VBG. So send a sample to this is the VBG. pH 6.96, carbon dioxide 25, bicarbonate 3. Sorry, it's wrong. Uh, 5 dioxide was 35, bicarbonate is 5. Sorry, it's wrong. What do you think? Bicarbonate 5, acidosis, carbon dioxide washout? Yeah, probably a urine coating bodies like you asked for is positive. So this is uh, it's a diabetic ketoacidosis. So you have to follow the DKA protocol. That is a separate lecture on its own. Why I did this? This happened to me when I was a post intern. So I was working in a hospital, looking after estate sector people. They are all were getting meningitis. So common. When we do LPs, the pus used to pour out. So whenever they come with this history, fever, confused. We do the we start antibiotics and just wait. So this is what I did, and then in the middle of the night, I went back and I slept, and I couldn't sleep because something was wrong. Those days we didn't check sugar like we do here. The strips are not available, so it was very rarely that. Not like now we check for everybody, any ill patient. So didn't check, but I couldn't sleep, so I went back and checked the sugar. It was high. So, I think those things don't happen much now, but always I did this case, always check sugar. Could be low, it could be high. It can happen. So don't go only according to pattern recognition. Always think objectively. So again, same case that we had earlier. 3 years old girl, previously well, drowsy since morning. Uh, so Yahweh was patent. Respirate was a little low. Saturation was normal. There was a mild tachycardia. Child is responding only to voice. There was no abnormal posture. Pupils were equal reacting to light. Afebrile. So sugar was normal. What is the cause of the drowsiness? So at this point you have stabilized A, B, C, D. Now you have to ask questions and find the cause. Any questions that you'll ask? If you ask the question, I'll tell you what was there. Doubt. Mike? Anyone? Mike here. Peter Bus. Yes. You'll pass the mic around and get, otherwise nobody will answer. Peter Bus. Yeah. Sleeping on the ground. Anything else you ask? Yeah. There were no bite marks, but child was sleeping on the ground. Anything you ask? So, will this happen in the Western province or Southern? Hmm. Yeah, so this patient was in the northern province, not here. So this child was sleeping on the floor, and there was a ptosis as well. There was no local swelling. So what's the snake? You're from Anuradhapur, no? Yeah, that's why you know. Yeah, it's a great bite. So you don't have it in the Western, Central, or Southern province. Uh, So treatment is antivenom, but always remember to make sure that these patients get respiratory arrest. So you have to monitor the respiration and see more than the antivenom, you might have to intubate and ventilate. This is a very common thing when we are working at Vaune. Every day in the morning, there will be at least one person coming like this. So at that time, all displaced people, they were living in temporary housing, sleeping on the floor. And in the night, it's cold in the northern province. So these crates, they come in and they pump the warmth. So they are lying next to the children. When the children move, they bite them. So this is we don't worry about CET or anything. We don't generally create, we don't see much bite. We might not see much local. So we know it's great bite when they come. But we have to check the other stuff as well, sugar and stuff. But we know by pattern recognition, we know what it is. So this one. So a 4-year-old girl presented with fever for 1 week, on and off vomiting, for your oral intake and reduce urine output. She has taken treatment 2 times. So give the mic to somebody else, no? Behind. Yeah. Yeah, you'll get. We'll get. Yeah. So Yavi was patent, but child is tachypnic, tachycardic, but good volume pulse, blood pressure normal, not in shock, but she's confused. Jesus is 13, pupils equal and reacting to light, no next difference. What will you do? Sugar was normal, no fever. That's the history and examination you will do to find out the cause. Anyone can shout at anything. What will you ask? The standard questions, you know the causes, no? So when you're managing quickly, you have to very quickly ask the patient one by one, one after another to find the cause. Otherwise, you will go in the wrong direction. What will you ask? Drowsy child? You all ask no anything. Yeah, no fever, headache. You're thinking of meningitis. There was no headache, fever, photopolar vomiting, nothing to suggest a meningitis. She was initially febrile, but the fever settled. That there was no features of meningitis. And she had come with a count. Count was a viral count, and CRP was not high. So we didn't think it was a meningitis. What else? Anyone? Hmm? Are you thinking of leptospirosis? No, there was no nothing. That's just she was not in the bed fields. Yeah. Yeah, that's a very good question. You have to always exclude poisoning. So you have to, what are the things you will ask? What are the common things that they get poisoned with? Yeah. So we asked, we couldn't find anything, but sometimes we won't get a history. So you have to ask about drugs in the home, whether the parents or any drugs or grandmother parents are there, whether they've gone to any place where they could have got, could somebody have given them a toxin, anything else? You don't ask trauma. We looked at the causes and asked always about trauma. You have to ask the full history, family history. Was there a fit? Was there convulsions, right? That's it. Full history of it. So this patient, actually real patient, uh, when we examine the patient, we actually asked about the drugs and initially they didn't tell us about any drugs. We examined, there was a liver. Liver was 3 centimeters. So what do you think the cause was? So what will you do next? So obviously you have to full history examination. You will have to look at the liver functions. It could be a liver failure, no? It could be a metabolic cause. And when you asked about this, they are given paracetamol 500 milligrams 6 hourly 4 days. So they actually didn't tell us this. We had to basically like interrogate like CID to get this out of them. And when we did the liver functions of above 1000, INR was high. And when we calculated the paracetamol dose, it was 133 milligrams per kg per day for 4 days. So it was a multiple super therapeutic dose of paracetamol. And on top of that, probably had a viral fever, which probably dengue without leaking, and had gone into liver failure. So if you have a patient, always the history examination, think of toxins, think of liver problems, think of renal problems, think of encephalopathy. So this child actually deteriorated and Needed intubation and ventilation, had neck, went into liver failure. We treated for liver failure, went to renal failure, we dialyzed. But child got better, perfectly well. Later on investigation, there was no other long-term liver cause. There was no autoimmune hepatitis, there was no Wilson's. Child was perfectly well. It was a multiple separate therapeutic overdose. So always look at toxins, non-accidental, accidental, multiple separate overdose of paracetamol. Look for liver failure, look for renal failure. This case, a 2-year-old boy presented with status epilepticus. So he needed 2 doses of midazolam and a phenytoin infusion to settle the fit. So child was afebrile. So there was a snoring sound. What will you do? Airway is blocked. No, so we needed to head till chin lift and needed an oral pharyngeal airway to maintain the airway. So child was tachypneic and getting on and off episodes of apnea and tachypnea, and we needed oxygen to maintain. So the pulse was 100 per minute, good volume, blood pressure 120 by 80. What will you do next? What will look in the D? Or PCU people? D. So you have to look at the postures and yeah. So just responding to the pain, GCS was 8, right pupil dilated, decellular posturing. So what is going on? What are the bad things here? What are bad stuff is here? No? So yeah, GCS is low. So we are worried about the airway and he's getting tachypnea, captain. There's abnormal breathing patterns. What do you think of this blood pressure? Yeah, if you look, it's quite high and this pulse rate, you'd expect it to move for ill child. No? So, and there's a dilated pupil as well and disabled. So a lot of signs for it is happening here. Yeah, there's raised ICP, it's a child with raised ICP and right pupil. So it's focal. There must be some focal thing on the right side. No? So this patient, what is going to kill first is you have to manage the ABC and you have to manage the raised ICP. So child is afebrile, sugar was normal. So previously well child, birth and development normal, no family history of convulsions, and a very vague history of trauma. When we asked said the child was running and slipped and he had fallen, mild trauma to the right side of the head. So raised ICP, how do we manage? We have to prop up the head in around 20 degrees. So propping up the end, that itself will reduce the ICP. So this child reduced GCS, will need intubation because to protect the airway, and we have to do it with the best person, with proper anesthesia, good sedation. Otherwise, if we don't sedate properly, the child is restless, crying, not sedated, the pressure will go up further. And you have to maintain good oxygenation because you have to maintain the oxygen supply to the brain. You have to maintain the carbon dioxide in the normal range. So when you're ventilating, you should monitor the carbon dioxide, make sure it's not going up. If it goes up, the carbon dioxide high causes vasodilation. So there is more flow to the brain that will increase the raised ICP further. If you ventilate too much and carbon dioxide is low, it will cause vasoconstriction, then you won't have enough flow to the brain. So you have to maintain a normal as possible. It's very important that you maintain the mean arterial pressure. If you don't have adequate pressure, the perfusion of the brain will be not enough and you will cause more damage. So you have to maintain the cerebral perfusion. Cerebral perfusion is equal to mean arterial pressure minus ICP. So you have to maintain the MAP and you have to reduce the ICP. So you might have to give some 3% saline bolus, maybe followed by infusion. And you have to maintain all the parameters in the normal level. Minimum disturbance for the child. Keep the head in the midline. No obstruction over the neck. Maintain the MAP. Maintain sugars, electrolyte, temperatures. Keep the child as normal as possible. And get a CT and neurosurgical referral. So this patient actually, I don't have the CT. It was a extradural hemorrhage which needed drainage. So this is the next case. So a 6-year-old girl presented with sudden onset of drowsiness for 4 hours duration. Previously well, no other problems. Said that he went to for swimming after school but was not in the pool, was outside. From that time onwards, drowsy. So she had gone to the private hospital and there they had noticed that the child has had a convulsion which settled from spontaneously. So they are transferred to LRH. So when we saw the patient, airway was patent. There was normal breathing, saturation 99, pulse was around 90 per minute, blood pressure 105 by 60. GCS was 10 out of 15. So pupils were bilateral dilated, but no other abnormal postures. So we have to now go through all the causes of reduced conscious level. So there was no fever. So it didn't look like no history of fever previously. It did not look like a meningitis. There were no rashes, no neurocuteal stigmata, no trauma. Sugar was normal. When you put onto the monitor, it was normal sinus rhythm. So we extensively asked us, no trauma. You asked over and over again for drugs, toxins. Doesn't always exclude it. There was no past history of fits, no family history of fits, normal birth and development, nothing to suggest a metabolic cause. There was no obvious renal or liver function disorder, but we sent those anyway. But only thing was pupils were bilaterally dilated and reflex was exaggerated. So we need a count. There's a bit of a high WBC with high neutrophil count, but not very significant. But sodium was normal. So always look at sodium. Potassium was normal. Blood urea was normal. ALT was normal. Calcium was normal. T9 was normal. APT2 normal. So why is she drowsy? So what will we do next? We have taken history examination. Child is drowsy. Pupils are dilated. Excited reflexes. What will you do? We have to do something. We can't ignore. Yeah, so we did a CT. So let me see what's there on CT. So in the ventricle, there's a hemorrhage and there's intraventricular and intracerebral hemorrhage. So we again, there was features of raised ICP, but this one didn't need ventilation, but we propped up, gave oxygen, minimum disturbances, maintained sugar and mean arterial pressure, gave some 3% saline, and we did the neurosurgical referral. So they thought it was a vascular malformation. So they needed to do some rupture of vascular. They needed to do some, they wanted to do a transfer the neuro ICU in NHSL and want to do a digital subtraction angiography to check the cause. But I think even without that, she was improving. But probably she'll come, we don't know whatever, she'll probably come back to LRH to one of your wards and figure out what exactly was there. Yeah. So in that case, we went through actually all the things that you have to take in the history examination investigations, including CC to find. Other than EEG, I think we have done everything. And you have to know how to manage the ICP and transfer to the correct place. So this one, similar to a case that we presented earlier, 7-year-old girl presented with fever 2 days, cough 2 days, drowsiness and GCS 9. So the airway was patent. Tachypneic, increased work of breathing, saturation 90, bilateral crepitations, pulse 180, severe tachycardia, poor volume pulse, capillary fill time 5 seconds, blood pressure 70 by 30, GCS 9, high fever. What will you do? What do you think the diagnosis? Yeah. So CBS is a 200 and blood gas, there's a acidosis with carbon dioxide 54, bicarbonate 14, lactate 6. What will you do? Here, a lot of stuff we have to do. So this child is hypovolemic as well as hypoxic. So it is a bilateral cavity. It's a pneumonia with septic shock. So oxygenation, you take your cultures and start VBGs and start fluid boluses. You can give in allocates of 10 to 20 ml per kg till the circulation is coming back to normal. So you might have to give more than 40 ml per kg. So you're giving more than 40 ml per kg. You'll have to start inotropes quickly. First line inotrope in children is adrenaline. Need IV broad spectrum antibiotics. So most likely a third generation cephalosporin and an aminoglycoside. And there's a carbon dioxide retention. Most likely will need intubation and ventilation and ICU care. So this patient, why we do is all drowsiness is not due to CNS causes. Look at the airway, breathing circulation. sort those out and manage those. If you go straight for meningitis in this patient, then child will die while you're managing. Yeah. So yeah, any questions? Drowsy. Okay, if there's no questions, summary, always use the ABCD approach to assess and manage. While you're doing this, take history and examination parallel to the resuscitation. Send the appropriate investigations. Image, if you need imaging, do it. And when you get a specific diagnosis with specific treatment, be able to recognize and treat raised ICP. And what is DEFG? Don't ever forget glucose. Don't ever forget sugar. Thank you.
I would like to thank Dr. Michael Jansz for his very valuable lecture. Again, I would like to invite Sir on stage to receive a token of appreciation. I would like to also invite Dr. Sudat Fernando, Vice President of Doctors Welfare Society of LRH, to present Dr. Michael Jansz with a token of appreciation for his valuable time spent with us today. Thank you much, sir, and thank you all for joining us today. I hope to gain your attendance in the next lecture also, which will be conducted on the first Wednesday at exact same time and same venue the next month as well. You can collect your lunch on your way out, and thank you.